bronchial asthma and COPD. For the first, we will talk about bronchial asthma. So bronchial asthma, the definition of this disease. Bronchial asthma is a pulmonary disease characterized by reversible, underline to yourself, reversible airway obstruction, airway inflammation, very important idea, and increased airway responsiveness to a variety of stimuli. So you must remember three characteristics, main characteristics of bronchial asthma. Asthma is reversible airway obstruction, it is inflammatory disease, and it is characterized by increased airway responsiveness to different stimuli. So bronchial asthma is a leading cause of hospitalization for children and the number one chronic condition causing school absences. So it means that bronchial asthma is a very important disease for adolescents and children, but also for adults too. Some words about pathophysiology of bronchial asthma. So once again, bronchial asthma is an inflammatory disease, allergic disease, which is characterized by airway obstruction. And airway obstruction in bronchial asthma develops due to a combination of factors that include spasm of airway smooth muscles of small bronchi, inflammatory edema of airway mucosa, increased mucus secretion, cellular, especially eosinophilic and lymphocytic in case of bronchial asthma, infiltration of the airway walls, and the last, injury and desquamation of the airway epithelium. So this picture illustrates normal bronchus and bronchus in case of asthma, bronchial asthma attack. So we see that all these mechanisms lead to narrowing of bronchus. So spasm, inflammatory edema, hypersecretion of mucus, infiltration and edema of mucosa. All these mechanisms lead to narrowing of bronchus during a bronchial asthma attack. So it means that the main syndrome of bronchial asthma is broncho-obstructive syndrome. So bronchospasm due to smooth muscle contraction is used to be considered the major contributor to the airway obstruction. But nowadays, inflammatory disease of the airways is known to play a critical role, particularly in chronic bronchial asthma. Even in mild asthma, there is an inflammatory response involving infiltration, particularly with activated eosinophils and lymphocytes, but also with neutrophils, sometimes mast cells, and epithelial cell desquamation also occurs. So this is very important idea. You must remember that bronchial asthma is allergic inflammation in which eosinophils play the main role. It means that our treatment must influence this allergic inflammation, even in mild bronchial asthma. Typically, all asthmatics with active disease have hyperresponsive or hyperactive airways, manifests as an excessive bronchoconstrictor response to many different stimuli. So once again, hyperresponsiveness or hyperactive airways means excessive bronchoconstrictor response to different stimuli. And the degree of hyperresponsiveness is closely linked to the extent of inflammation, the number of eosinophils in peripheral blood and airway secretions, and both correlate closely with the severity of the disease and the need of drugs. So once again, we discussed main characteristics of bronchial asthma. Bronchial asthma is an allergic inflammatory disease of small bronchus, in which this inflammation eosinophils play the main role. This inflammation leads to bronchospasm and hyperresponsiveness of airways. So the main ideas about pathophysiology of bronchial asthma. Classification of bronchial asthma. Bronchial asthma is divided due to etiology into atopic or extrinsic and non-atopic or intrinsic. Also occupational and aspirinic. According to the cause of bronchial asthma, it is divided into easy, occasional, mild, persistent, moderate, persistent, and severe persistent. According to the phases, it is divided into exacerbation and remission of bronchial asthma. And the last very important classification, controlled and uncontrolled bronchial asthma. So, according to the degree of severity, once again, it is divided into 4 grades: mild intermittent, mild persistent, moderate persistent, and severe persistent. And in order to assess the degree of severity of our patient, we must carefully analyze his symptoms, the severity and frequency of symptoms. So how much bronchial asthma attacks per week? Are there nighttime symptoms? Is there physical activity limitation, and so on? And we also need to perform spirometry, because we must know the level of forced expiratory volume in the first second, because according to the level of this spirometry parameter, we divide bronchial asthma in degrees of severity. And we must learn this classification according to the degrees, because according to this classification, we start initial treatment of our patient. That is why without knowledge about the degree of severity, you can't start treatment of your patient, proper treatment of the patient. Classification according to the control of bronchial asthma. So bronchial asthma may be controlled and uncontrolled, and sometimes also partial control is also may be assessed. So how to assess control? We may use special questionnaires like on the screen. It is called Asthma Control Test, or AST. It is filled by the patient himself once in 4 weeks. The patient answers 5 questions. For example, question number 2. During the past 4 weeks, how often have you had shortness of breath? And patient will answer, for example, once or twice a week, it will be 4, score 4, or not at all, will be score 5. And then we calculate the total score. And if the total score is more than 90, 20 and more, it is controlled, well-controlled bronchial asthma. If your patient has total control less than 19, for example 15 or 12, it means that his asthma is not under control. Why is it important to know if your asthma controlled or uncontrolled? Because the main goal of our treatment of our patients is to achieve well-controlled bronchial asthma. That is why we must monitor control of bronchial asthma. We must know how to assess asthma control. It is very important for treatment of our patient. We also may use such tool for assessment of asthma control. In this case, the doctor, the physician, performs the assessment of asthma control. So we must answer 4 questions. Presence of daytime symptoms more than twice a week, reliever needed more than twice a week, any night walking, so nighttime symptoms, and any activity limitation due to bronchial asthma. So if we have all negative answers, it means that your patient has no symptoms of bronchial asthma. So it means that we will put him to the green part of this tool. It means that asthma is well controlled. If your patient has 3 or 4 positive answers, it means that his asthma is uncontrolled, is out of control, and you will put him to red part of this assessment tool. So don't forget about this very useful classification and the tools, the methods of assessment of asthma control. So we continue. Now we are going to talk about symptoms of bronchial asthma. So bronchial asthma is characterized by occasional episodes of expiratory dyspnoea, expiratory shortness of breathing. And the frequency and severity of symptoms vary greatly from person to person and from time to time in the same person. Some asthmatics have occasional episodes that are mild and brief. Others have mild coughing, wheezing much of the time, punctuated by severe exacerbations after exposure to known allergens or viral infections or physical exercises or some non-specific irritants. Psychological factors, particularly those associated with crying, screaming, or sometimes hard laughing, may precipitate the symptoms of bronchial asthma attack. So the bronchial asthma attack may be provoked by different types of triggers. Asthma triggers may be stress, may be environmental pollution, some strong odors or smoking, dust, cold air, exercise, pets, and so on. And so on. So don't, you must differ asthma triggers and allergens. For example, cold air is not allergen, but it may provoke bronchial asthma attack. Or smoking. Cigarettes are not allergens, but they may provoke bronchial asthma attack. And allergens are pets, pollen, bugs, fungus, and so dust. These are the allergens. So contact with these asthma triggers may provoke bronchial asthma attack. And allergens are divided into two groups: external or extrinsic allergens, such as dust, different types of food, for example, eggs, strawberries, and salmon, medical drugs, and some others. And endogenic allergens or intrinsic allergens. This is microbial antigens. So it means that your patient, for example, has persistent bacterial or viral inflammation, for example, chronic bronchitis or bronchoectasis, and the products of decomposition of microbes and tissue proteins forming due to proteolytic process at the inflammatory focus can act as allergens. That is why bronchial asthma is divided into two main groups: atopic. In case of atopic bronchial asthma, external allergens play a role, and in case of intrinsic or non-atopic bronchial asthma, endogenic or intrinsic allergens, microbial allergens, will play role in inflammation. So what about attack? Attack of bronchial asthma. Usually an attack of bronchial asthma begins with paroxysms of wheezing, coughing, shortness of breath, or incidentally with slow increasing manifestations of respiratory distress, especially in children, and itch over the anterior neck or upper chest may be an early prodromal symptom, and dry cough, particularly at night and during exercise, may be the sole presenting symptom. The cough during an attack, an acute attack, sounds tight and generally does not produce mucus. So this is very important. The cough during the bronchial asthma attack is dry without sputum. Except in young children who rarely expectorate, tenacious mucoid sputum is produced as the attack subside. So during physical examination, we talked about complaints or symptoms. So once again, bronchial asthma main symptom is attack. Attack of bronchial asthma is expiratory shortness of breath, dry cough, and wheezing. Three main symptoms. On physical examination, during an acute attack, the patient shows varying degrees of respiratory distress depending on the severity and duration of the episode. Maybe tachypnoea. Tachypnoea means increased frequency of respiratory movements more than 17 per minute. Maybe tachycardia. It means heart rate more than 90 per minute. The patient prefers to sit upright or even leans forward, uses accessory respiratory muscles. So this position is called forced position, and its name orthopnoea position. Remember this name of forced position of the patients during bronchial asthma attack. It is called orthopnoea position. The patients are anxious and may appear to struggle for air. also very important symptoms of bronchial asthma attack. And so this is example of orthopnea position of our patient with participating of axillary muscles in respiration. So chest examination during bronchial asthma attack shows a prolonged expiratory phase with relatively high-pitched wheezes. They are called whistling throughout inspiration and most of expiration. The chest may appear hyperinflated due to acute air trapping during bronchial asthma attack. Air trapping during asthma attack. During more severe episodes, the patient may be unable to speak more than few words without stopping for breath. Fatigue and severe distress are evidenced by rapid, shallow, ineffectual respiratory movements. On examination of the skin, we may find cyanosis, sometimes even confusion and lethargy may indicate the onset of progressive respiratory failure with carbon dioxide narcosis. So this is severe bronchial asthma attack, severe bronchial asthma. In such patients, a less wheezing may be heard on auscultation. It is very important symptom because extensive mucus plugging and patient fatigue result in marked reduction of airflow and gas exchange. So it means that a quiet sounding chest in a patient having an asthma attack is an alarm that the patient may have a severe respiratory problem that can quickly become life-threatening. So pay attention on this idea. Less wheezing or quiet sounding chest in case of bronchial asthma attack is an alarm. So the most reliable signs of a severe attack are dyspnoea at rest, expiratory dyspnoea, inability to speak, cyanosis, pulsus paradoxus, participating of accessory respiratory muscles in respiration, and the severity of bronchial asthma attack may be assessed by measuring arterial blood gases. So we need to measure arterial blood gases. This is the classification of bronchial asthma attack, severity of bronchial asthma attack. Mild, moderate, and severe. So we use such parameters as breathiness, toxin, alertness, respiratory rate, accessory muscles use, wheezing, pulse rate per minute, peak expiratory flow, PEF. So by the peak flowmetry, not spirometry, but peak flowmetry may be used for assessing of the severity of bronchial asthma attack, and by the level of this parameter, PEF, we may assess the degree of severity of bronchial asthma attack. So if PEF more than 80%, it is mild, from 60 to 80% moderate, and if it is less than 60, it is severe bronchial asthma attack. And saturation of hemoglobin by oxygen on room air. Normally it must be more than 95%. If it is more than 95%, measured by pulse oximeter, it is mild bronchial asthma attack. If it is from 91 to 95, it is moderate bronchial asthma attack, and less than 91, it is severe or life-threatening bronchial asthma attack. But between acute attacks, breath sounds may be normal during quiet respiration. However, fine wheezes may be audible during forced expiration or after exercises. Loud to moderate grade wheezing may be heard at any time in some patients, even when they feel asymptomatic. With long-standing severe asthma, especially if dating from childhood, chronic hyperinflammation may affect the chest wall, for example, producing a squared-off thorax, anterior bowing of the sternum, or a depressed diaphragm. So once again, I emphasize that bronchial asthma has two periods: exacerbation or bronchial asthma attacks, which are provoked by allergen contact, and the remission, or the time between acute attacks. So, what do we need to confirm our diagnosis? What laboratory and instrumental methods do we need to confirm our diagnosis? So, for the first laboratory findings, complete blood count. In complete blood count, if your patient has allergy, it means atopic bronchial asthma, the amount of eosinophils will be increased. It is called eosinophilia. And in many asthmatics, the degree of eosinophilia correlates with severity of bronchial asthma. More severe, more eosinophilia. Next, sputum examination. In a patient with uncomplicated bronchial asthma, sputum is highly distinctive. It is tenacious, rubbery, and whitish. Only in presence of bacterial infection it may be yellowish, especially in adults. Many eosinophils, often arranged in sheets, are seen microscopically, and eosinophilic granules from disrupted cells may be seen throughout the sputum smear. And the most specific symptom is elongated dipyridamel, charcot-laden crystals originating from eosinophils. So, three most characteristic symptoms: eosinophils, eosinophilic granules, and charcoal-laden crystals are detected in the sputum of the patients with bronchial asthma attack. And these symptoms are the symptoms of allergic inflammation of bronchus. And we must use pulmonary function tests, spirometry. So the spirometry helps us to assess the degree of airway obstruction and disturbance in gas exchange. We measure the airway's response to inhaled allergens and chemicals. It is called bronchial constriction testing. Or we may quantify the response to drugs and follow patients of the long term. So it will be bronchodilatated test. Pulmonary function testing is most valuable when performed before and after giving a bronchodilatator, and in this case we can determine the degree of reversibility of the air obstruction. And at the beginning of lecture I emphasized that bronchial asthma is characterized by reversible bronchial obstruction. So you must know that spirometry may be static and dynamic. And from physiology, you know static lung volumes and capacities, such as total lung capacity, functional residual capacity, vital capacity, and some others. And what about dynamic lung volumes? Dynamic lung volumes are forced expiratory volume in the first second, forced vital capacity, and the ratio between forced expiratory volume in the first second to forced vital capacity. So for detecting bronchoobstructive syndrome, we use these three parameters. So attack is bronchospasm and leads to development of obstructive type of ventilation disorder. This disorder is characterized by decreased forced expiratory volume in the first second and the ratio of forced expiratory volume for the first second to forced vital capacity. Normally, these parameters must be more than 80% of predicted. It means that bronchoobstructive syndrome is characterized by decreasing of these parameters less than 80% of predicted. In some cases, air trapping and increased residual volume results in hyperinflation of the lungs and leads to the development of restrictive type of ventilation disorders. This type is characterized by decreased vital capacity, decreased forced vital capacity, and normal or even increased ratio of FIV1 to forced vital capacity. And in some cases may be mixed type of ventilation disorders. It means that all parameters will be decreased. Mixed type means the combination of obstructive type and restrictive type. So this is example of obstructive type of ventilation disorder. If we pay attention at the table, at the result of spirometry, we see that forced expiratory volume in the first second is less than 80%, it is only 71%, and the ratio of forced expiratory volume to forced vital capacity is 17. So these are the symptoms of obstructive type of ventilation disorders. And if we pay attention at flow volume loop, which is recorded during registration of dynamic spirometry, this loop has inspiratory part, which is under the easy line, and expiratory part, which is above the easy line. And this triangle is the normal flow volume loop of this patient. And this is measured. So it means that patient has decreased lung volumes, and you see that the shape of the flow volume loop is also changed. The top of volume loop is decreased. The top must be here and patient has here. So it means that forced expiratory volume for the first second is decreased. And the shape is like a tooth, shark tooth. So it is specific shape of volume flow loop in case of obstructive type of ventilation disorder. Restrictive type. So if we analyze the result of spirometry, we see that forced vital capacity is extremely decreased, vital capacity is extremely decreased, and the ratio of forced expiratory volume to forced vital capacity is even increased. And if we pay attention on the flow volume loop, we see that in case of restrictive type of ventilation, the shape of loop is looking like normal, but it is extremely narrowed. It means restrictive type of ventilation disorders. And mixed type, when we have all parameters decreased. So what else we may need for diagnosing of bronchial asthma? Maybe chest X-ray. Findings in case of bronchial asthma vary from normal type to hyperinflation during attack. Lungs markings are commonly increased, particularly in chronic asthma. So we also need allergen identification because bronchial asthma is allergic inflammation, allergic disease. So we need allergen identification. Allergens suggested by the history, but they must be medical history of our patient, but they must be confirmed by an allergy evolution that includes skin testing, for example. Inhalation bronchial provocation testing can be used with allergens to establish the clinical significance of positive skin tests, or with methacholine or histamine to assess the degree of airway hyperresponsiveness in known asthmatics. It also aids in diagnosis when the symptoms are atypical. So this test may help us to differ bronchial asthma from different types or from other different diseases with bronchoobstructive syndrome. Treatment. So treatment starts from assessing of the severity of bronchial asthma and monitoring the course of therapy. Then we must control environmental factors to avoid or minimize precipitating symptoms of exacerbations, and use drugs to manage exacerbations and to reverse and prevent airway inflammation, and provide education that fosters a partnership between the patient, family, and healthcare providers. About environmental control, so if possible, allergens should be eliminated. Certain allergens, for example, dust mites, molds, pollens, may be selected for a trial of allergy immunotherapy. Aspirin should be avoided, particularly by patients with nasal polyposis, so with an aspirinic bronchial asthma. Beta blockers, including those used topically to treat glaucoma, also worsen bronchial asthma. We must avoid them. And anti-asthmatic drugs. Anti-asthmatic drugs can be divided into two groups. Those used for symptoms relief. It is short-acting beta agonist SABA, theophylline, and SAMA, short-acting antimuscarinic drugs, and those which are used for long-term control. They are anti-inflammatory drugs. They are corticosteroids, predominantly inhaled corticosteroids, leukotriene modifiers, and cromolyn and nedocramil. These cromolyn and nedocramil are used only in children and adolescents. So, and pay attention on this principle, step principle of treatment of bronchial asthma patients. It is used for initial treatment of our patients. So once again, we must confirm the diagnosis. We must assess the degree of symptoms, degree of severity of bronchial asthma, and then we must put our patient to one of the steps of treatment. For example, patient has symptoms most days, night symptoms once a week or more, and low lung function. It means persistent, severe persistent or moderate persistent bronchial asthma. In this case, we must put our patient in the step 4. It means that we must use medium dose inhaled corticosteroids for basic treatment for in order to influence the inflammation, with combination with LABA, long-acting beta agonists. We use this treatment for 3 months. After 3 months of treatment, we must once again assess the control of bronchial asthma. If bronchial asthma is controlled, it means that asthma control test score is more than 19, we will put our patient to the step 3. It means that we will decrease the dose of inhaled corticosteroids. But if our patient will have uncontrolled bronchial asthma, we will put this patient to the step 5. It means that we will increase the dose of inhaled corticosteroids. We will use high dose in combinations with LABA, or we may use some combinations with other phenotypic assessment treatment. So we will use add-on therapy. Once again for 3 months, then control assess, and we make a decision what to do with the patient. Continue this 5-step or going down. So if you want to know more about bronchial asthma, you may use these guidelines that are called Global Initiative for Bronchial Asthma. In order to know the most modern treatment, you may use the guidelines which were updated in 2020. These guidelines are updated each year, but the most modern are 2020. You may use them. They are in internet. You may download this material and know more about bronchial asthma. So that's all about bronchial asthma. Now we were going to continue and we will focus on chronic obstructive pulmonary disease, COPD. So COPD is a disease characterized by chronic bronchitis or emphysema. So COPD is a combination of chronic obstructive bronchitis and emphysema and airflow obstruction that is generally progressive and may be accompanied by airway hyperactivity and may be only partially reversible or irreversible. So this is the difference between bronchial asthma and COPD. So COPD comprises emphysema, lung emphysema, and chronic bronchitis, two distinct processes, although most often present in combination. Etiology or predisposal factors of COPD. So the first, smoking. Smoking is the most important etiological factor of bronchial asthma. Smoking, alterations of epithelial ciliary function, alveolar macrophages depression, hyperplasia of mucoid glands, and bronchospasm. So smoking leads to these mechanisms. The next etiological factor may be air pollution in cities. Next, infections, viruses, bacteria, mycoplasma. Hereditary and genetic factors. Alpha-1 antitrypsin deficiency plays a very important role in COPD development. Alpha-1 antitrypsin deficiency may be primary according to the hereditary. It is about 10% of COPD. And alpha-1 antitrypsin deficiency may be secondary. And secondary alpha-1 antitrypsin deficiency is connected with smoking. Smoking leads to oxidative stress development, and this oxidative stress is a cause of secondary alpha-1 antitrypsin deficiency in patients with smokers, in heavy smokers who will develop COPD. So main factors, once again, contributory to COPD development are, first of all, smoking, air pollution by sulfur dioxide and other products of incomplete inflammable combustion, organic and inorganic dust such as cotton, grain, coal, and some others. Their prolonged influence leads to bronchial mucus glands hypertrophy and significant increase of mucus secretion, which gains mucopurulent or purulent character under the influence of bronchopulmonary infection. Gradually, inflammation spreads over all bronchial wall and fibrosis is developed. So it means that chronic bronchitis, so COPD is inflammation of bronchus is called chronic bronchitis, and gradual inflammation of all bronchial wall leads to fibrosis. In some smokers with rough changes of bronchi and peribronchial tissue, bronchiectasis may form. Bronchiectasis means dilatation of bronchus. So this picture illustrates that two processes are developed in case of COPD. One is chronic bronchitis And the second is lung emphysema. They are developed parallel in lungs of COPD patients. Clinical manifestations. So patients with COPD are most often tobacco smokers with a history of at least 1 pack per day for at least 20 years. This disease is only rarely seen in non-smokers. Onset is typically in the 5th decade of the life. The first symptom will be cough with thick and sticky sputum. Chronic cough increases in cold weather or addition of bronchopulmonary infection. In this case, fever appearance, mucopollular and sputum, and occurs due to bronchial obstruction, frequently accompanied by bronchospasm. The next very important symptom, dyspnoea or shortness of breathing. This dyspnoea has expiratory character, and this dyspnoea limits exercise tolerance progressively. So it means that COPD has progressive course. Next symptom is cyanosis. Cyanosis means bluish skin color. And we talked that two processes develop in lungs, bronchitis and lung emphysema. That is why there are two variants of COPD, bronchitic variant and Amphithematosus variant. Now we're going to talk about bronchitic variant. Chronic bronchitis most frequently leads to development of irreversible inflammatory fibrous changes, it means pneumosclerosis of small bronchi, and makes up the base of COPD. Tobacco smoking is the most frequent etiological and supporting progress of illness factor. Due to high frequency of cyanosis and heart failure, patients with chronic bronchitis are described as blue bottles because they have cyanosis and they have like edema due to heart failure. That is why they are blue blotters. In this variant of obstruction, after inflammatory edema of terminal bronchial mucus resulting in alveolar hyperventilation, the partial pressure of oxygen decrease and of carbon dioxide increase, so hypoxemia and hypercapnia develop. The spasm of alveolar capillaries and hypertension in lesser circulatory circle occur. That is why patients will develop hypertrophy of right ventricle and right atrium. It is called copulmonale, so right ventricle and right atrium hypertrophy. In case of pulmonary hypertension, in patients of COPD is called copulmonale. And when right ventricle heart failure develops, these patients will have peripheral edema, for example, leg edema. Clinical manifestation, clinical symptoms of copulmonale are the first cyanosis, distended jugular veins, enlargement of abdomen due to hepatomegaly and ascites, edema, and positive venous pulse. So these are the symptoms of chronic right heart failure. Palpation of the heart region detects cardiac beat and pathological epigastric pulsation of the right ventricle. Percussion may reveal widening heart dullness to the right due to right ventricle and right atrium hypertrophy. On auscultation, we will reveal accent of S2 above pulmonary artery, sometimes systolic murmur of tricuspid insufficiency, or diastolic murmur of pulmonary artery insufficiency, and sometimes gallop rhythm. The next variant, the second variant, is Amphithematosus variant. In this case, it is more widespread type of COPD in which cyanosis is not expressed, but dyspnoea is prominent, very prominent, and these patients are called pink puffers due to this dyspnoea. So this picture illustrates two types of COPD. This picture of emphysematosus type of COPD, and this is a patient with bronchitis type of COPD or blue blotter. So emphysema, lung emphysema, is lung disorder characterized by decreased of pulmonary tissue elastic properties, alternations of alveolar wall structures, enlargement of the air spaces distal to the terminal bronchioles, with collapsing of later on inspiration and airflow obstruction. So this is the definition of lung emphysema. This picture illustrates lung emphysema, pan-ecceneric lung emphysema, which is characteristic for COPD. So we see dilated alveolar ducts and alveolar sacs, and this is anatomical presentation of pan-ecceneric lung emphysema. This is also lung emphysema. Pathogenesis of lung emphysema has yet to be determined with certainty. Although most workers favor an imbalance of proteases and antiproteases in the lungs, with resultant lung destruction. And this theory is based on the discovery of a small number of patients with an inherited deficiency of alpha-1 antiprotease, the major antiprotease, which develops emphysema even without other risk factors. And once again, cigarette smoking, the major etiological factor of the development of lung emphysema, has been shown to increase the number of alveolar macrophages and neutrophils in the lung, enhance protease release, and impair the activity of antiproteases. However, other factors must determine susceptibility of emphysema, because fewer than 10 to 15% of smokers develop clinical evidence of airways obstruction. So alveolar walls and supporting structures destruction leads to formation of significantly enlarged air spaces. It is accepted to think that tissue skeleton absence in lower airways leads to their narrowing due to dynamic collapse on expiration on the level of small pulmonary volumes, so-called expiratory bronchial collapsing. Furthermore, alterations of blood-air membranes decrease lung diffusion capacity owing to the lung respiratory surface decrease. Normally, proteases activity is regulated by inhibitors synthesized in liver. Alpha-1 antiprotease, alpha-1 antitrypsin has the largest activity among them. Increase of neutrophilic elastase, catepsin, metalloproteinases, and decrease of antiproteases activity are detected in some patients. These conditions are frequently accompanied by lung emphysema development. So, the symptoms on physical examination in case of lung emphysema. So, we will detect hyperinflated lung syndrome of lung emphysema. It means that patient will have barrel shape of the chest. The accessory muscles will participate in respiration. We will detect decrease of chest respiratory exertions, measuring of chest circumstances on inhalation and exhalation, decrease of diaphragm excursions, and depression of lower lung bodies on topographic percussion. Both-sided decrease of vocal fremitus, widespread hyperresonant or bandbox percussion sound above lungs, which may even replace the superficial cardiac dullness zone, diminishing of vesicular breath sounds on auscultation, and sometimes wheezes if broncho-obstructive syndrome presents. On X-ray may help us to detect lung emphysema. We will see widened intercostal spaces, like in this example, widened intercostal spaces, horizontal ribs position, increased of lung pattern lucidity also will be detected. Laboratory testing. In case of COPD, we need complete blood count. In this case, we will detect increased red blood cells and hemoglobin and deceleration of erythrocyte sedimentation rate. This will be the symptoms of hypoxemia. In case of infection, bacterial infection, white blood cells will be increased, neutrophils may be left shift, and accelerated erythrocyte sedimentation rate. If we will perform pulse oximetry, we will detect a decreased saturation of hemoglobin. By oxygen, it will be less than 94% in case of respiratory insufficiency presence. And we may perform blood gases. In this case, we will detect decreased oxygen hypoxemia and increased carbon dioxide, carbon oxide, the hypercapnia. About instrumental methods, we need ACG. ACG we need in case of presence of copulmonale. So we must detect right ventricle and right atrium hypertrophy. Right atrium hypertrophy is detected by change of P wave. P wave is atrium wave. In this case, it will be high and acute. It is called P pulmonale. And we may detect right ventricle hypertrophy by air wave. Air wave will be high, more than 7 millimeters in right chest leads V1, V2, and S wave will be very deep in left chest leads V4, V6. And we also may use echocardiography or cardiac ultrasound, which detect the signs of right ventricle enlargement and its dysfunction and pulmonary artery hypertension. And spirometry, of course, we need spirometry to confirm the diagnosis of COPD. And once again, we may detect obstructive type of spirometry or restrictive type of spirometry in case of lung emphysema. Or it's more often we may detect combined or mixed type of disorders, of ventilation disorders in case of COPD. Once again, obstructive type of spirometry is characterized by decreased forced expiratory volume in the first second less than 80% of predicted, and by decreased ratio of forced expiratory volume in the first second to forced vital capacity less than 70% of predicted. And restrictive type is characterized by decreased vital capacity and forced vital capacity less than 80% of predicted. And we need spirometry for detection of airflow limitation of the severity of COPD. So by the level of forced expiratory volume in the first second, the airflow limitation is divided into 4 degrees of severity: mild, moderate, severe, and very severe. Mild when FIV1 is more than 80, moderate FIV1 is between 50 and 80%, severe in case of FIV1 between 30 and 50%, and very severe when FIV1 is less than 30%. So, and then after performing spirometry and assessment of the degree of airflow obstruction, we must put our patient in one of the groups of COPD. There are 4 groups of COPD: A, B, C, and D. It is very important to know the group of your patient, because treatment we will apply according to this group. So once again, we must perform spirometry and detect bronch obstruction. Then we must assess the degree of airflow limitation by forced expiratory volume in the first second level. Then we must carefully analyze the medical history of our patient. So we must know his exacerbation history. The exacerbation history may be 0 or 1 exacerbations per year which are not leading to hospital admission, or more than 2 exacerbations, or more than one exacerbation, but this exacerbation is leading to hospital admission. And then we must assess the severity of symptoms. The severity of symptoms we assess by questionnaire. I use CAT, COPD Assessment Test questionnaire. There are some questions. The patient fills in this questionnaire himself, then we have a total score. So if total score of CAT COPD assessment test is maybe less than 10 or maybe more than 10. So if CAT is less than 10, it means that his symptoms are not frequent and they are not severe. If CAT is more than 10, it means that he has frequent and severe symptoms. So, and then we assess the group of our patient. So if patient has very frequent exacerbations and very frequent and severe symptoms, CAT more than 10, we will put him to the group D. If patient has no exacerbations and has very rare symptoms, so his CAT is less than 10, he will be A group, and so on. So this is one more illustration of classification of COPD groups, but in this case is used another questionnaire, MMRC, Modified Medical Research Council Dyspnoea score. It is equal to CAT. And now when we know the group of our patient, we may choose appropriate treatment. So if we have a patient group A with low symptoms and low risk of exacerbation, we may apply SABA or SAMA, short-acting beta agonist or short-acting antimuscarinic drugs as needed, or as alternative choice LAMA or LABA, and so on. So once again, to know the group of COPD, to assess the group of COPD, very important for applying appropriate treatment of our patient. So, and other principles of treatment includes fighting against factors caused chronic bronchitis and emphysema, smoking cessation, active therapy of infections and bacterial infections, bronchospasm relief. So we use SAMA, SABA, LAMA, and so on. Physical exercises to increase physical activity tolerance and training of respiratory muscles. This is a very important part of treatment. Postural drainage in case of presence of bronchiectasis, and very important, oxygen therapy. Oxygen we apply in case of copulmonary development and chronic respiratory insufficiency. If you want to know more about chronic obstructive disease, lung disease, you may use these guidelines, GOLD guidelines, Global Initiative for Chronic Obstructive Lung Disease. It is also updated each year. So if you want to know more, you may use these guidelines.